So today we are here to discuss about a disease, which has different domains, a very heterologous disease, a difficult to treat disease. And it's very exciting for me to announce that we are going to be talking about a new drug in our armamentarium for the treatment of psoriatic arthritis, and a drug which is going to get launched perhaps very soon. And I think some knowledge and some look into the evidence will help you decide how and when to use this drug. So I'm going to basically start off with three excellent speakers, Dr. Samashif Bandyopadhyay, who's going to address the unmet needs in this disease called as psoriatic arthritis. Followed by myself, I'm going to discuss the Spirit 1 and Spirit 2, the data on basis of which this drug got its approval. Followed by Professor Handa, who's going to discuss the Spirit head-to-head trial between ixekizumab, which is the drug we are going to talk about today, and adalimumab, and he'll also discuss the safety data. So I would request both our speakers, Professor Handa and Dr. Samashif Bandyopadhyay, to please come on the dais. And I would request Dr. Samashif Bandyopadhyay to address the unmet needs in this disease, psoriatic arthritis, which is so difficult, which has so different domains, and we are yet far from achieving a good clinical response with most of the drugs. Dr. Samashif Bandyopadhyay, please.
Evening, my respected teachers, I would say, and friends. Psoriatic arthritis is a very challenging condition, as Dr. Roth has already said, and we are trying to see how we can approach with a newer drug with new ability in our hand to treat it. Now, as we all know, that psoriatic arthritis is a heterogeneous disease involving multiple domains. The pictorial manifestation tells us briefly about its musculoskeletal involvement, including peripheral arthritis, spondylitis, enthesitis, dactylitis, skin and nail changes, the psoriatic skin changes, nail psoriasis, and being a chronic systemic inflammatory condition with musculoskeletal and non-musculoskeletal manifestation, it has got quite a significant disease burden for patients who suffer from it. It's classified as one of the spondyle arthropathy due to its shared clinical features with other forms of spondyle arthropathy. This is a radiographic picture of peripheral joints. It's a progressive condition with joint damage. You can see bone erosions and ectopic bone formations accumulating over time. Hence, early diagnosis and treatment is absolutely mandatory to preserve the joints. It is a mutilating condition. 20% of the patients develop a destructive and disabling forms of arthritis, and 50% of the patients develop one erosion 2 years from the onset of the condition. If you look at the prevalence, if you see the peripheral arthritis, then it could be oligoarthritis, which is the most common form, or polyarthritis, which is less common. Axial involvement, it involves lumbar, thoracic, and spinal, the cervical spine with about 25 to 50% prevalence, dactylitis, which is swelling of the entire digit with 40%, and enthesitis varying from 25 to 50%. Psoriasis, the skin changes, it can be with or without obvious psoriatic skin lesions, and as my teachers have taught us over time, that we have to clinically look for these skin changes in specific areas behind the ear, navel areas, back of the hair, so on and so forth. Nail changes, the onycholysis and nail pitting, is very common, and if one looks for it with some vigor, it is not a very difficult sign to pick up. Uveitis, though rare, can happen, as well as inflammatory bowel disease, which includes ulcerative colitis, Crohn's disease, and other forms, which are not very common but can be associated. We all know that why we are having this meeting. We are having this meeting because psoriatic arthritis significantly impacts our daily living for the patient. It is to this extent of turning a faucet on and off, dressing oneself, including shoelaces and buttons, walking outdoor on flat grounds even, and bending down to pick up small objects from the floor. And a study confirmed that persistent symptoms of psoriatic arthritis with swelling, pain, stiffness significantly impact all such activities. And it does cause real difficulty for the patients to do their daily job, living, and whatever. If we look at these, then you will see that all the psoriatic arthritis patients, mostly with 4 affected joints and enthesitis and dactylitis, will have problems in all domains of these basic activities of life, which we take as granted for ourselves. Hence, tight control of these disease is important because it improves long-term joint damage and related outcomes. Tight control, if we look at the graph, we'll see that the tight control of multiple domains improves clinical outcome and quality of life. And you can see that in this domain of involvements, even in the corona study, which is an older study, only 1 in 4 patients treated with biologics, mostly TNF at the baseline, achieved the minimal disease activity in psoriatic arthritis. So, despite the availability of treat-to-target strategies, which are important for every rheumatological condition currently, many patients may be undertreated in psoriatic arthritis. We have got multiple guidelines and recommendations for treatment of psoriatic arthritis, including GRAPPA, EULAR, and ACR. And the principles overall for each of the domain of psoriatic arthritis, potential treatment targets include remission or low level of disease activity. The exact targets are not agreed on all these recommendations and guidelines. In managing patients of psoriatic arthritis, consideration should be given to each musculoskeletal manifestations with treatment options and decisions made accordingly, and non-musculoskeletal manifestations like skin changes, eye changes, GI involvement, and comorbidities should be addressed separately. The treatment approach, if we look at the recommendation, promote and escalation strategy. That means that failure of CDMARDs, TNF alpha, then IL-12-23, IL-17, IL-23, and JAK inhibitors are recommended as the first-line agent for treatment. EULAR recommended BDMARDs with no distinction between any of the DMARDs any of the biologics we commonly use, like the TNF alpha or IL-23 or IL-17 in most of the cases. In some cases, like the peripheral arthritis or axial disease or predominant enthesitis or dactylitis, immediate treatment with biologics are warranted. So, unmet treatment needs. While treatment guidelines, as we have mentioned, recommend treating all domains to remission or low disease activity, many patients fail to achieve such. Not all patients have responses to all treatments which are effective across all domains. That means some patients get very good skin response, some get very good dactylitis response. So all domain response across the board may not be available or may not be achieved by all patients. CDMARDs are recommended prior to biologics with limited evidence supporting their use, but as we all know that cost is an important factor for such treatment. Lack of effectiveness cited in most of these domains are reasons for discontinuation of TNF treatment, and skin is one of such areas where people get frustrated with the psoriatic skin changes. Now, patients who have failed one TNF are less likely to respond to second TNF and many other biologics. Hence, there's a need for therapies with new mechanism of actions that can offer effectiveness across all domains in all population affected by the condition, which is also uh, includes the TNF failure patients. So in summary, if we just quickly look at the psoriasis and the psoriatic arthritis being a heterogeneous systemic inflammatory condition that affects multiple domains, there's an unmet need in the therapeutic armamentarium, which has got sustained efficacy across all domains, particularly in patients where TNF failures are there. Treatment targets that cover multiple domains were shown to be associated with better outcome in the quality of life as well. And clinical practice varies globally, and some guidelines using this treat to target approach, some based on the clinical scenario, and others recommend treatment options by individual clinical domain. Now, IL-17 producers and responders, many cells, as we know, are capable of secreting IL-17. They're the innate immune system cells, as you can see, and then the adaptive immune system cells as well. And many cells express the IL-17 receptor and are capable of responding to the blockers. We all know that IL-17 is an important component in synovitis. They have got impact on fibroblasts like synoviocytes, macrophages, neutrophils, and then they go through the MMP pathways, and then they stimulate the fibroblasts like synoviocytes to produce IL-6 and MMPs. They cause a proliferation characterized by hypervascularity and increased infiltration of neutrophils, cartilage degradation, and IL-17, IL-8 induces the movement of neutrophils into this synovium and hence the inflammation. We know that IL-17 has got role in pathogenic bone remodeling. And if we look at IL-17 and its impact on osteoblasts and upregulation of rank-Lydin, we see that there is indirect stimulation of cells to produce factors that promote osteoclast maturation, including rank-Lydin, and upregulation of rank-Lydin expression and promotion of osteoclast differentiation. So from pre-osteoclast, we get mature osteoclast, MMP3s are produced, and then there is bone degradation. And as we have said, the fibroblast-like synoviocytes, they then promote IL-17 into pre-osteoclast to mature osteoclast. So there's a lot of bone remodeling and bone degradation associated with it. IL-17 is also into enthesitis. As we know, there is muscle tendon insertion and there is neutrophilic infiltration with environmental triggers and mechanical stress and microbia. So ixazimab has got some key attributes. As a molecule, it has got half-life of about 13 days. It's an IgG4 monoclonal antibody that targets IL-17 with high binding affinity. This inhibition of IL-17 may be effective, prevent joint damage and enthesial inflammation, cartilage and bone degradation, and possibly ectopic bone formation. And there are ixazomib clinical trial overviews, which sir will explain in detail the spirit P1, P2, and P3, and it will be picked up in the later talks. And I now hand over to Professor Roth for next session. Thank you.
Thank you, Dr. Samashish Bandyopadhyay, for that very good introduction. So I'm going to talk about the role of ixekizumab in psoriatic arthritis. This is a new drug, and two landmark trials, the Spirit 1 and the Spirit 2. These are my disclosures. So the Spirit 1 was basically designed in patients who were refractory to conventional synthetic DMARDs. And there were three arms. So there was a placebo arm and there were two ixekizumab arms, one on 82 weekly and the other on 4 weekly with a start dose of 160 milligrams. And there was an active reference arm. This was not a comparative arm, but a reference arm of adalimumab. And at week 24, both the placebo and the ADA arm were then randomized to the ixekizumab arm. At 16 weeks, if there was an inadequate response, they were allowed to modify the treatment. At 32 weeks, if there was no response, according to the defined criteria, the drug was discontinued. The Spirit 2 again was a 3-arm, 2 ixekizumab, start loading dose of 160. One was 2 weekly 80 mg and the other one was 4 weekly 80 mg. And then there was a placebo arm which was randomized to ixekizumab at week 24. Now, this was in patients who were refractory to biological DMARDs, mainly anti-TNF. So when we look at the data of ixekizumab, and this is the ACR 20, 50, and 70 response at week 24, and you find that very good responses in ACR 20 of almost 60% and almost 50% in ACR 50 and 30% in ACR 70 responses. And this was in conventional synthetic DMARD inadequate responders. But what is even more heartening is to see that in inadequate biological responders, in inadequate TNF responders, the response was equally good. So almost 50% in ACR 20, 35% in ACR 50, and almost 22% in ACR 70. So significantly more patients responded in both DMARD inadequate responders and anti-TNF inadequate responders with ixekizumab. Also, when we look at the modified SHARP scores, we see that there was a significant decline in the radiological progression at week 16, which was maintained through week 24. When we talk of resolution of enthesitis, we can see that in almost 40% of the patients in both DMARD inadequate responders and TNF inadequate responders, and you can see hardly any difference. Even with TNF inadequate responders, the resolution of enthesitis was very, very promising. Almost more than 30% of ixekizumab treated patients experienced improvement and resolution of enthesitis. When we talk of resolution of dactylitis, again, you can see that in both Spirit 1, which is DMARD inadequate responders, and in Spirit 2, which was TNF inadequate responders, very similar responses in resolution of dactylitis. So even in TNF failure patients, dactylitis resolved equally well with ixekizumab as they would with conventional synthetic DMARD inadequate responders. When we look at the fingernail psoriasis clearance rates, again, you find that at week 24, there was significantly better clearance of nail psoriasis in the ixekizumab arm in both DMARD refractory and TNF refractory patients. So clearly working very well all through. The PASI response rates at 24 weeks, again, you could see whether you had patients who were conventional synthetic DMARD inadequate responders, you had almost a PASI 100 in more than 50% of the patients. And what was even heartening was that in TNF inadequate responders, there were almost 30% of the patients who had response. And now when we look at the composite disease measurement indexes like the MDA, we look at the DAPSA and the psoriatic arthritis response criteria, we find that in all these domains, both in conventional synthetic DMARD inadequate responders and TNF inadequate responders, there was a very robust 40 to 50% responses with ixekizumab. And I think the key is this. So what are the effects of ixekizumab with concomitant use of conventional synthetic DMARDs and the use of prior TNF? So the most important thing here is to see that irrespective of whether you use a synthetic DMARD like methotrexate, even with methotrexate or without methotrexate, the response was very, very similar. So this could be a drug which could be used as a monotherapy in a disease which is so heterologous, which has multiple domains. You could use this as a monotherapy because irrespective of your conventional synthetic DMARD, the response rates in 20, 50, and 70 ACR responses were equally good. So the addition of a conventional synthetic DMARD did not make a difference to the drug. And the second most important thing is, irrespective of the prior use of TNF, whether you had used one TNF or you had failed two TNF, the Spirit 2 showed us that at week 24 and week 52, irrespective of the number of anti-TNFs you had failed, the drug had shown good responses in both the ACR 50 responses rate at week 24, so which was very, very heartening. So is ixekizumab effective, and is this efficacy maintained in long term? So I've shown you it's very effective, but let's look at the long-term data. So when you look at the ACR 20 response rates, right up to week 56, we see that the response which comes as early as 2 to 3 weeks is then maintained right through week 156. And the same is with ACR 50 responses, again maintained very well. And ACR 70. So all responses were maintained right through week 156. What about enthesitis? Again, you see a steady improvement, and then that improvement has been sustained. The resolution of dactylitis, very similar data, very robust response at the end of 12 weeks and then sustained right through week 156. And same with nail psoriasis. So almost every domain improved robustly, and then the improvement was sustained right through the end of the extension studies. So the PASI scores, 75, 90, and 100, all improved. So to summarize, in biological naive and TNF inadequate responders, ixekizumab treatment resulted in rapid clinical and meaningful improvement across all manifestations, all domains of psoriatic arthritis. What was very heartening to see that this effectiveness was maintained irrespective of whether you use a concomitant DMARD or you don't use a concomitant DMARD. And what was also very interesting to see that irrespective of the number of TNF failures prior to the use of ixekizumab, it responded reasonably well across all the domains. And not only it responded well, the response was sustained up to 3 years. And with that, I would now like to call Professor Handa to discuss the Spirit head-to-head trial, which was the comparison with adalimumab, and then discuss the safety of this drug. Professor Handa, please.
Thank you very much, Dr. Dutt. My brief is to give you data about the comparison with adalimumab, and this is the well-cited Spirit head-to-head trial. I've been a speaker for several companies, and I'm contracted by Eli Lilly for this talk. The head-to-head Spirit trial had a very interesting design. These were biological naive patients, but they needed to have two domains: active psoriatic arthritis and psoriasis, skin psoriasis, more than 3% of the body surface area. This was open label, assessor blinded trial, and the primary endpoint was at week 24, and I'll show you data on that. This was patients simultaneously achieving ACR 50 and PASI 100. So this was the primary endpoint, that you needed to improve both on the articular front as well as the cutaneous front. And this is data, as you can see, the curves separate out quickly. In the red is ixekizumab, and this is adalimumab. And at week 24, there was a statistically significant difference. More patients with ixekizumab improved on the articular and the cutaneous fronts simultaneously, and this was maintained through week 52. And if you look at the ACR 20, 50, and 70 responses, this is in keeping with the trial data elsewhere. About 70% ACR 20, 50% ACR 50, and ACR 70 is about 30%. This is in almost all populations. And this was the major secondary endpoint, patients achieving ACR 50 at week 24, and this was almost similar to adalimumab. The other thing was PASI 100 response at week 24, and this is where the curves separate out. On the articular front, I showed that they were nearly similar, but if you look at the cutaneous front, more patients on ixekizumab achieved PASI 100. So complete clearance, as they say now, is the goal of treatment. And this is where the IL-17 inhibitors step in. And this is data for ixekizumab. And this is again data which has been shown in the other SPIRIT trials. The trial program has similar data looking at the minimal disease activity, very low disease activity. This is DAPSA, low disease activity, remission, week 24, week 52, and both these papers were published in the Annals of Rheumatic Diseases. The SPIRIT head-to-head was the first completed trial on head-to-head comparison. Now, psoriasis has other domains as well. What about enthesitis, which can be troublesome in some patients? This is data on resolution of enthesitis, week 24 and week 52, and as you can see, similar to adalimumab, this is resolution of enthesitis, again statistically significant at week 24 with ixekizumab. And then we have dactylitis. So we've talked about two domains, the important ones, the cutaneous and the articular. We have data on enthesitis. This is data on dactylitis, and this is week 24 and week 52. Ixekizumab was effective on this domain, and this is the nails. So this is the challenge of psoriasis, and this is the difference from rheumatoid arthritis, that you need to have drugs which work equally well on all domains. And apart from the efficacy on different domains, we now have safety data. This is the efficacy data in, the different subsets. And this was monotherapy without the conventional synthetic DMARDs. This was concomitant methotrexate. And this was with other conventional synthetic DMARDs, like in real life, sulfasalazine, leflunomide. And as you can see, the difference was maintained. This is in red is ixekizumab, and this is adalimumab, and this was a head-to-head trial. And this is simultaneous achievement of ACR 50 and PASI 100 with or without methotrexate. Ixekizumab could stand on its own, and this is the similar to what Dr. Rath had mentioned. What about safety outcomes? And this is equally important. Whenever you have a new introduction, one is concerned about safety. This is adalimumab compared with ixekizumab. Treatment emergent adverse events about 70% in both the groups. Serious adverse events 12 and 4, 0 deaths. And this is infections, candida infections, injection site reactions, allergic reactions, cardiovascular, cerebrovascular events, malignancies, and there was no untoward safety signals. The overall summary from this trial, which was the first completed study, and there was a similar study with secukinumab, EXCEED trial, we'll not go into that. this was superior to adalimumab when you looked at the simultaneous achievement of ACR 50 and PASI 100. And I again remind you that the treatment goal for dermatologists now is complete clearance. The study also met the key secondary endpoints. Ixekizumab performed as well as adalimumab across the musculoskeletal domains with a faster onset of action, but showed significantly greater efficacy on the skin and nails as compared to the anti-TNF agent, and the safety profiles were consistent with the approved labels. And then we have data from the integrated spirit trials. And in the interest of time, I would just go through this to say that they use total exposure time, then they use the exposure adjusted incident rates, and this is now also published by Atul Deodhar, and this is the incident rates. And overall, the treatment emergent adverse events were in about 80% of the patients, but serious adverse events were in only about 9.6% of the patients, and about 8.2% discontinued the drug. And this was in keeping with the global literature available with the other agents. There were 4 reported cases of pregnancy. And this is the data on this. This drug is not approved for use, but this is what is the safety data which is available. The birth type was full term. The outcome was normal in 2, and in 2 patients, there was elective termination. So the safety profile, all in all, threw up no new or unexpected safety signals. And this is where I end, because we have some very senior people sitting in the audience, and I would like to invite comments, questions. Thank you very much.
Thank you, sir. Thank you so much. Yeah, Professor Mukherjee, please.
Professor Mukherjee, please.
In all spondyloarthropathy group, essence of pathology is inflammation and osteoproliferation. We are all using TNF inhibitors, we are all using IL-17 inhibitors. Now, what about the effect of this new drug, istikizumab, on osteoproliferation? This is number 1. Number 2, in patients of psoriatic arthropathy, some of them come with uveitis, where we have got IL-17 inhibitors are contraindicated, whether it has got any safety profile over there. Because main point, the skin lesions go away very quickly. Dactylitis is an inflammatory component. Enthesitis is inflammatory component, they go away. But what is happening to the osteoproliferative changes in the long run, that will determine the efficacy of a drug on a long-term basis in the treatment of psoriatic arthropathy with a multi-domain clinical manifestation.
Very well taken. I think in the uveitis part of it, I'm not sure whether there is data on the uveitis part of this, but with, yes, Dr. Rajesh, yes, please. Can you come up to the mic? With secukinumab also, it's available that they have looked at the patient population with uveitis and there was no apparent worsening. Yes, please.
Thank you, everyone. So I'm Dr. Rakesh. I'm a Lilly employee, so please consider that disclaimer. And there are no particular studies which have been done in uveitis population. But with regard to clinical trials, there are no safety signals which are associated with uveitis. So we didn't see that concern of uveitis. But again, in that subgroup, we don't have a trial data. And with regard to osteoproliferative data, again, you showed the MTSS data. Sir showed the MTSS data.
Yeah.
Again, it has reduced the progression. Other than that, we don't have any supporting data that it will improve with regard to the bone proliferation.
IBD data was shown that,
again, in IBD, interleukin 17 ideally should be avoided. So it's better to avoid interleukin 17, whether it's ICSI or SECU. It's better to avoid in IBD.
Dr. Rao and then Dr. Rao. I think.
Well, we have Rao square and both come from the same.
Having used secukinumab, I have this question about: is there a dose-dependent variation in the cutaneous response?
So,
Number one.
uh,
Number two, what any data on NSAID dependence? Because we know it's a very NSAID dependent disease for dactylitis or arthritis, especially peripheral arthritis or PSA SPA. Those are the two questions.
The cutaneous approved dosing is higher than the
Yeah.
articular dosing, and I think that's every 2 weeks for
Yeah.
6 weeks after the loading of 160 milligram. And for the approved dose for psoriatic arthritis is once in 4 weeks. Am I right, Dr. Rakesh?
Yeah.
Yes, sir. If patient has moderate to severe plaque psoriasis, then there is an induction regimen of every 2 weeks till week 12, and then it is once in 4 weeks. But if patient doesn't have moderate to severe plaque psoriasis, then it is once in 2 weeks after a initial dose of 160 mg.
Yeah.
And this is true for all agents where the dose for the skin may be more than what you require for the joints.
Sir,
Skin sometimes can.
yeah, if I may just add something. See, I know this is the common thing that comes to our mind that we already have secukinumab. What makes secukinumab different? Just a word about the basic molecule. So, secukinumab is an IgG1 molecule. This is an IgG4 molecule. The reason why they have chosen IgG4 over IgG1 is that IgG4 seems to be much more inert in the sense that it doesn't trigger an antibody dependent cell mediated cytotoxicity 1. It doesn't cause complement activation 2. The only problem with IgG4 using it as a backbone was that IgG4 is a very unstable molecule. It splits to form, these dimers. To prevent that, they've done something very unique. If I'm not wrong, they've changed the serine for proline in the hinge region, which makes it very stable. So this is a very inert molecule. It's not going to cause any problems with the primary immune system. So that's probably what makes it so unique or different from secukinumab.
And the one more difference is the eye binding affinity, which Dr. Shamshish.
high binding ability. I think that's also very important because this is very much more high binding affinity. So obviously that will make it more useful in that sense.
Dr. Rao, you are there.
Yeah, it's a nice presentation, all of you. I'm a bit concerned about the injection site reactions. It looked to be far higher than the TNF.
That's the data which I have shown, but maybe the company people can answer more about.
Definitely, there were a lot of injection site reactions. Close to 15 to 17% of the patients experienced injection site reaction. But again, the best part is most of these injection site reactions were mild to moderate, and most of these reactions were redness, swelling, those kind of things, which went away after a few days. But again, this concern will be there, and it's better to counsel the patient about that. Patient will definitely experience. And we have seen in the psoriasis data over 5 years, 18,000 patient year data, that only 6 patients discontinued because of ISRs. So it's a very, very low discontinuation rate. But again, definitely it will be seen in at least 10 to 15% of the patients.
Sir, if I may just add on, we have done ixazomib trial in our hospital, and we had 6 patients randomized in the trial, and we had no such problem. It also depends on how it is injected and whether it is rubbed or not. I think that sort of very small things did matter. So that's one thing to keep in mind as well.
I think we need to close the session, and I would like to end by mentioning that the availability of new molecules means that our patients have access to more choice of agents. And eventually, given the challenge that psoriatic arthritis poses, we now have a repertoire of drugs, the conventional synthetic DMARDs.
Unfortunately, because we'll be launching the molecule somewhere in the month of February, March. I think we'll be disclosing the cost. I think we have the brand manager also. It is not yet revealed, so we may be revealing soon. I hope that it won't be a deterrent for you to prescribe to a right patient. Again, it is not yet revealed, so I'm not the right person.
So we actually have now a range of agents. We have tofacitinib, we have apremilast, we have secukinumab, and now the new kid on the block, ixekizumab. And in this meeting, we'd asked this question, and at this point, The commercial details are not yet available. This is to whet the appetite of clinicians that we now have more agents in our fight against psoriatic arthritis. And I must thank my other colleagues on the dais, the attendees, and the company. Thank you very much.
Thank you, sir.
Thank you, sir.